Welcome to Respiratory Virtual Grand Rounds. I'm Dr. Raed Dweik, Director of the CME Activity and Director of the Pulmonary Vascular Program at the Cleveland Clinic. These Grand Rounds are case-based presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing your patients. For today's presentation, I have asked Dr. Nizar Jarjour to provide you with an update on management strategies for severe asthma. Dr. Jarjour is Professor of Medicine and Head of the Division of Allergy, Pulmonary, and Critical Care Medicine at the University of Wisconsin-Madison, where he is also the Assistant Director of the Institute for Clinical and Translational Research. Dr. Jarjour earned his Doctor of Medicine degree from Damascus University School of Medicine in Syria. He completed his residency in internal medicine at Cook County Hospital in Chicago, Illinois, and his pulmonary and critical care medicine fellowship training at the University of Wisconsin Hospital and Clinics in Madison, Wisconsin. Dr. Jarjour is voted among the best doctors in America and frequently speaks on asthma at national and international meetings and has been a member of the multi-center Severe Asthma Program since its inception. Dr. Jarjour is a fellow of the American College of Chest Physicians and the American College of Physicians. He is a member of the American Thoracic Society, former president of the Wisconsin Thoracic Society, and a former chair of the Scientific Program Committee of the ATS Assembly on Allergy, Immunology, and Inflammation. He is currently a member of the Pulmonary Subspecialty Section of the American Board of Internal Medicine and a member of the FDA Pulmonary and Allergy Drug Advisory Committee. Dr. Jarjour's case-based presentation has built-in audience response questions that are designed to help you test your knowledge as you follow along. Here's Dr. Jarjour.
Thank you, Raed, for the kind invitation and nice introduction. I appreciate the opportunity to speak with you today on management strategies for severe asthma. Here are my disclosures. Financial disclosure, I'm a consultant for asthmatics and received research support from GSK. I have also important educational disclosure to share that I'm a member of the ABIM Pulmonary Medicine Exam Committee, and as such, I agree to keep the exam information confidential, and therefore no exam questions will be disclosed in my presentation. Today, our learning objectives include appreciation of the common factors that contribute to difficult-to-manage asthma, understanding the defining features of severe asthma, and recognizing the potential approaches to management of patients with severe asthma. It's great that this year we had two major publications related to severe asthma. In particular, the ATS ERS International Guideline on the Definition, Mechanism, Evaluation, and Treatment of Severe Asthma, published earlier this year in the European Respiratory Journal. And more recently, in May 2014, the Global Initiative for Asthma, GINA guidelines, were updated and published, and they do include a section on severe asthma. I will use these two guidelines during my case presentation and discussion of possible treatment options. Let's start with this case summary. This is a 54-year-old woman who presents with difficult-to-control asthma. She had asthma for more than 20 years, and of late, she had increased daytime symptoms, limiting her activities, and more frequent nocturnal awakening due to asthma. She's currently on high-dose inhaled ICS and LABA, in addition to taking albuterol as needed. On physical examination, she had stable vital signs. BMI was 33 kilogram per meter square, and she had occasional scattered wheezing. On spirometry, her FEV1 was 1.65 liters, or 60% of predicted, and FEV1 to FVC ratio was 48%, reflecting severe obstruction. Laboratory studies showed WBC of 8.2 with 7% eosinophil and serum IgE level of 225 international units per ml. So, we start with our first question. Which of the following is needed before concluding that this patient has severe asthma? A, consider and exclude other diagnoses such as vocal cord dysfunction, CHF, restrictive lung disease. B, confirm that the patient has asthma. C, evaluate and treat comorbidities such as poor adherence, environmental exposure, D, stress the proper use of and adherence to current medications, then reevaluate in 3 months. And E, all of the above. The answer is all of the above. In patients with difficult to manage asthma, we need to assess comorbidities and contributing factors, including adherence to medication, rhinosinusitis, obesity, reflux disease, exposure to smoke, whether first-hand or second-hand smoke, allergen and occupational irritants, anxiety, depression, and sleep apnea. These need to be looked at and reviewed in every patient who is having difficulty managing and controlling their asthma before concluding that the patient in actuality has severe asthma. There has been several definitions used for severe asthma. The most recent was adopted by the ERS ATS workshop, which states that severe asthma requires treatment with high-dose inhaled corticosteroids plus a second controller such as LABA or systemic corticosteroids to prevent asthma from becoming uncontrolled or asthma that remains uncontrolled despite this therapy. The issue of control has been the focus of societies and guidelines over the past several years. And the ATS ERS recommends that any one of the following qualifies as uncontrolled asthma: poor symptom control, 2 or more severe exacerbations requiring prednisone bursts over the past year, a serious exacerbation requiring hospitalization in previous year, or the presence of airflow limitation defined as FEV1 less than 80% in the presence of FEV1 to FVC lower than predicted following medication withhold. To improve understanding of severe asthma and to help develop better treatment, the NIH in 2001 initiated the Severe Asthma Research Program, which is currently in its 3rd cycle of funding. We now have 7 clinical sites and a data coordinating center working together to better understand this disease. One of the first papers from the Severe Asthma Research Program, including a description of patients with severe asthma in comparison to those with mild and moderate disease. As you can see on this slide, patients with severe asthma had significantly lower FEV1% predicted, but maintained a significant reversibility with 20% improvement in their FEV1 on average following inhaled bronchodilators. These patients had severe asthma not because they were not taking their medication, but despite taking their medication. 98% of them were on ICS, 32% were taking oral corticosteroids, 89% on LABA, and 50% were also on leukotriene modifying agents. So despite taking these medications, patients with severe asthma remained symptomatic and or had decreased lung function. These patients had a very high resource utilization with frequent emergency room visits in the past year, as can be seen on this slide, with nearly 40% of patients with severe asthma coming to the emergency room in the past year, and more than 20% of them being hospitalized. This is significantly higher than what was noted in patients with moderate or mild asthma. More recently, the Severe Asthma Research Program published a pulmonary prospective paper in which a summary of the first 10 years of investigation that included 1,600 patients, 600 of them had severe asthma, were highlighted. Some of the important features noted in the first cycle of Severe Asthma Research Program investigation included air trapping as a feature of severe asthma, as can be seen on this slide. Patients with severe asthma had significantly increased residual volume compared to patients with non-severe or healthy controls. In addition, the imaging studies from severe asthma showed that these patients had airway remodeling with correspondent airway trapping, as can be seen on these two panels. The upper panel shows patients with mild asthma and a CT scan that highlights airway wall thickness, which was significantly greater in the lower panel, where a patient with severe asthma was imaged. Corresponding to these airways are areas of air trapping, noted with these green bright dots, and a biopsy obtained from the noted airway that showed a thicker subbasement membrane in patients with severe asthma in the lower panel compared to patients with mild disease in the upper panel. Regional variation in severe asthma was further highlighted with the use of hyperpolarized helium ventilation MRI. As shown in this slide, a patient with asthma inhaled the hyperpolarized gas, and series of images were obtained during inspiration and expiration. The bright spot during inspiration show where the gas went. The dark spots reveal where the gas was not able to enter because of airway obstruction or dysfunction. As can be seen on this image, there were multiple areas of ventilation defects reflecting airway dysfunction in this patient with asthma, even though the lung function was within normal range. This brings me to our next question. In patients with severe asthma, which of the following approaches is recommended according to current guidelines? A, high-resolution chest CT scan. B, sputum-eosinophil-based therapy. C, adjusting therapy according to exhaled NO levels. D, none of the above. And the answer is none of the above. And here's why. For chest CT, the GINA and ERS ATS guidelines did not recommend obtaining CT scan routinely in patients with severe asthma unless they have a specific indication for chest CT, such as atypical presentation or lung cancer screening in smokers when appropriate. So the use of CT scan at this time remains, for the most part, a research tool. Sputum-guided therapy gained a lot of interest in recent years because of studies that showed improved asthma control when this management approach is taken. However, according to the GINA and ERS ATS guidelines, sputum-guided therapy is generally not recommended in patients with severe asthma. Both guidelines made exception for their use, and they recommend using it in centers that are experienced in this technique because obtaining adequate and accurate sputum eosinophil percent require certain level of expertise that is generally not available except in centers that specialize in managing and evaluating these patients. How about exhaled nitric oxide? We know that elevated FeNO suggests asthma diagnosis and increased likelihood of responding to ICS therapy. However, there are other reasons where exhaled nitric oxide can be elevated, and studies of asthma therapy guided by nitric oxide have not shown it to be consistently effective. Therefore, GINA and ERS ATS guidelines did not recommend the routine use of FeNO to guide therapy in patients with severe asthma. That brings me to our question number 3. Which of the following approaches is recommended in patients with severe asthma who remain uncontrolled despite using high-dose ICS and LABA? A, Theophylline. B, LTRA. C, Omalizumab. And D, Tiotropium. The answer to this question is C, Omalizumab. And here's the rationale. While Theophylline and LTRA are used in these patients, they are generally of limited benefit. An exception perhaps would be aspirin-sensitive asthma, where LTRA should be considered. One interesting choice would be Tiotropium, where randomized controlled studies have recently shown tiotropium to be equivalent to LABA or to have additional benefits in patients who are already on ICS and LABA and having ongoing symptoms. However, we need to note that this therapy has not yet been approved for use in asthma in the United States. Omalizumab was introduced for asthma therapy more than a decade ago based on two large trials that are summarized on this slide, where the number of exacerbations was significantly reduced following treatment with omalizumab in patients with allergic asthma. The studies by Soleil and Bassi both showed roughly a 50% reduction in the number of exacerbations per patient during therapy compared to placebo. In addition, omalizumab has been shown to improve quality of life, reduce symptoms, and can do so despite reduction of ICS use. There is a concern about anaphylaxis, but this is quite uncommon and will require monitoring the patient for 2 hours after the first 3 treatments, and if no problems, then the monitoring could be loosened a little bit. This therapy can reduce airway inflammation, and there's a potential for reduction in airway remodeling with chronic treatment. The recent guidelines by GINA and ERS suggest using omalizumab in patients with severe asthma who are allergic and remain uncontrolled despite using high-dose ICS and LABA, which is GINA step 4 therapy. Also, the ERS guidelines recommend monitoring patients' response, looking at their symptoms, exacerbation, quality of life, and doing so after a 4-month therapeutic trial. If patients are going to respond, they should show response in 4 months or so. And those who respond, it is perhaps reasonable to continue therapy. If they don't respond after 4 months treatment, one may need to consider discontinuation of therapy or alternative approaches. Which brings me to question number 4. After 6 months of optimized medical therapy, our patient remains symptomatic with frequent exacerbations. So now which one of the following is appropriate to consider? Long-term treatment with macrolides, bronchial thermoplasty, methotrexate, or antifungal therapy? Well, the correct answer is bronchial thermoplasty, and here's why. While the therapeutics noted on the slide have had studies that showed potential benefits, to date, the use of macrolides, methotrexate, and antifungal agents is not recommended in patients with severe asthma due to their limited benefits or side effects. However, there is an exception in patients with severe asthma who also have allergic bronchopulmonary aspergillosis, where antifungal therapy is recommended according to the ERS ATS guidelines. So why use bronchial thermoplasty? Well, we have known for a while that patients with severe asthma have increased airway smooth muscle mass. This is one of the studies by Pepe et al. On the left side, you can see biopsies of the airway that showed mild asthma in the upper panel and more severe asthma in the lower panel. The large area of pink, if you would, are areas of airway smooth muscles, and these are larger in patients with severe asthma, and the arrows also highlight the fact that the smooth muscle layers tend to be closer to the lumen in patients with severe asthma. In addition, in this study, there was a correlation between smooth muscle area and FEV1, such as patients with higher airway smooth muscle area had lower FEV1, as shown on the right side panel of the slide. So bronchial thermoplasty is a controlled heat that is applied to visible airway through a wire basket. This is introduced by a fiber optic bronchoscope and is presumed to work via reduction in airway smooth muscle mass related to applied heat. Generally, 3 bronchoscopy procedures are needed to treat airways in both lungs, and typically the airway of the right middle lobe are not treated. Controlled studies using bronchial thermoplasty versus sham bronchoscopy and monitoring patients over 1 year's time have shown that the quality of life of patients with bronchial thermoplasty increased significantly following the therapy. The average increase in asthma quality of life questionnaire score was about 1.3 points in patients with bronchial thermoplasty. However, as you can see on this slide, patients with sham bronchoscopy who did not have bronchial thermoplasty applied also had a significant improvement in their asthma quality of life scores, increasing on average by about 1 point. There was still a statistically significant difference between therapy and sham, roughly about 0.2 AQLQ score points that has been maintained throughout the year. Based on that study, the treatment was approved for use in patients with severe asthma. As a secondary endpoint, the frequency of severe asthma exacerbation after thermoplasty was reduced compared to sham bronchoscopy. And more recently, Wexler et al. Published the frequency of severe asthma exacerbation after treatment and reported a reduction in severe exacerbation, as you can see in the left side panel, as well as reduction in severe exacerbation rate for subjects per year in the right panel. These data are from a patient who underwent active thermoplasty, but the sham bronchoscopy subjects were not included. Still, it does seem that there was a reduction in exacerbation that was maintained during the 5-year follow-up. GINA guidelines concluded that bronchial thermoplasty may be considered in some adults with severe asthma, but noted the limited evidence for benefits and the unknown long-term effects, while the ERS ATS guidelines and a recent Cochrane review from 2004 called for further research on bronchial thermoplasty. In summary, we have discussed possible approaches to severe asthma and highlighted that a significant minority of patients with asthma have persistent symptoms and also ongoing inflammation and obstruction despite being on multiple controller medications. In patients who are difficult to control, we need to address the following first: triggers for asthma, comorbidities, adherence to medications, and alternative diagnoses. Those patients who remain uncontrolled after these factors have been addressed likely have severe asthma. In such patients, we should first optimize inhaled ICS and LABA therapy, increasing the dose of ICS, ensuring proper inhaler technique, and encouraging adherence to prescribed medications. In certain patients, low-dose maintenance oral steroids can be considered, keeping in mind that side effects need to be closely monitored. Other therapies to consider include Leukotriene receptor antagonists, particularly in patients who are aspirin sensitive. Theophylline has been used but is of a limited benefit in severe asthma. And Tiotropium has probably similar benefits to LABA or additional benefits in patients who remain symptomatic on ICS and LABA. However, this treatment is not yet approved for asthma. There are currently phenotype-guided approaches that can be recommended and hopefully more to come in the near future. For allergic phenotype subjects, anti-IgE, currently the only available medication is Omalizumab, can be recommended. And for patients with persistent eosinophils, particularly in the sputum, RCS therapy adjusted based on sputum eosinophils in centers that are able to perform these procedures can be recommended. There are non-pharmacological interventions in a subset of adults with severe asthma that can be considered, such as thermoplasty in carefully selected patients. I hope that I have been able to cover some of the important aspects of severe asthma, the recent development in our understanding of this disease mechanism, and currently available approaches to its management. Thank you.
Thank you, Nizar. In his presentation, Dr. Jarjour started with a case to highlight the updated definition of severe asthma based on the recently published American Thoracic Society, European Respiratory Society guidelines. He emphasized the importance of evaluating for triggers, comorbidities, adherence to medications, and alternative diagnoses before making the diagnosis of severe asthma. He shared insights from the Severe Asthma Research Program regarding the clinical characteristics of severe asthma, resource utilization by these patients, and other lessons learned from this program. Dr. Jarjour then focused on management strategies based on the Global Initiative for Asthma and ATS-ERS guidelines, and specifically discussed the roles of induced sputum and exhaled nitric oxide in monitoring the disease, and the roles of Omalizumab and bronchial thermoplasty in severe asthma therapy. I hope that you found Dr. Jarjour's presentation on management strategies for severe asthma to be a useful update on this topic, and it will help you with the day-to-day management of these patients in your practice. Finally, on behalf of myself, Dr. Jarjour, the Respiratory Institute, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.